A preliminary impression is an impression made for the purpose of diagnosis or for the construction of a tray. A final impression is an impression for making the definitive master cast. The master casts are used in constructing the dentures. The objectives of an impression are to register the tissue in such a manner that the prosthesis developed will provide support, stability, and retention. It should record the potential denture-bearing surfaces and the peripheral limiting tissues which enhance retention. By maximally extending the denture to cover areas of support, stress on any one area is reduced. A snowshoe is a common analogy. The tissue should be in a healthy state. The impression should extend to include all supporting tissue within the limits of function of the tissues. Borders of the denture must be in harmony with the anatomic and physiologic limitations of oral structure. A physiologic functional type of border registration should be accomplished. Adequate space must be provided for impression material. The impression should be accomplished without damage to the oral tissue. Ideally, the patient will leave their existing denture out for 24 hours prior to the impression. Alternatively, tissue conditioners may be placed in the existing denture prior. This assumes much greater importance when making a definitive impression, as opposed to a preliminary impression. The orbicularis oris is the main muscle of the lip and forms the outer surface of the labial vestibule. The tone depends on the support it receives from the denture flange and artificial teeth. The fibers anastomose with the buccinator in the area of the buccal frenum, one pulling the frenum forward and the other pulling rearward. There are several structures in the maxillary arch with which you should be familiar. These structures will be recorded in your impression. The first of these is the labial frenum, followed by the labial vestibule, the buccal frenum, the buccal vestibule, the coronoid bulge, the residual alveolar ridge, the maxillary tuberosity, the hamular notch, the posterior palatal seal area, the fovea palatini, the median palatal raphe, the rugae, and the incisive papilla. The vibrating line is an imaginary line drawn across the palate that marks the beginning of motion in the soft palate when the patient says "ah." At the midline, it usually passes about 2 millimeters anterior to the fovea palatini. These are indentations near the midline of the palate, formed by the coalescence of several mucous gland ducts. They are always in soft tissue, which makes them ideal as a guide for the location of the posterior border of the denture. Additionally, the distal end of the denture must cover the tuberosities and extend into the hamular notches. The ultimate support for the maxillary denture is the hard palate. It is very resistant to resorption. The alveolar ridges change when the teeth are extracted. Resorption of the ridges is rapid at first, but continues throughout life at a reduced rate. The crest of the ridge is an important area of support. However, due to resorption, it should be looked at as a secondary area of support. Mucosa also supports the denture. The black arrows denote the line of demarcation between the attached and unattached mucosa. Attached mucosa is desirable for support. However, it is the peripheral area that contributes to the border seal. The configuration of the bone that provides the support for the maxillary denture varies considerably with each patient. Among factors that influence the form and size of the supporting bone are the condition of the bone prior to extraction and the length of time the person has been edentulous. Some variables include the palatal torus, the maxillary tuberosity, the location of the incisive foramen and papilla, and the presence of sharp, spiny processes. The labial vestibule, the buccal vestibule, and the vibrating line comprise the limiting peripheral structures of the maxillary denture. There are several mandibular anatomic landmarks with which you should be familiar: the crest of the residual ridge, the buccal shelf, the mental foramen, the genial tubercles, and the coronoid process. The crest of the residual alveolar ridge is covered with fibrous connective tissue, but in many mouths the underlying bone is cancellous and without good cortical plate covering it. Because underlying bone is often cancellous, the crest of the ridge may not be as favorable as the primary stress-bearing area. The area between the mandibular buccal frenum and the anterior edge of the masseter muscle is known as the buccal shelf. It is bound medially by the crest of the residual ridge, laterally by the external oblique ridge, and distally by the retromolar pad. The total width of the bony foundation in this area becomes greater as the alveolar resorption continues. The reason is that the width of the inferior border of the mandible is greater than the width at the alveolar process. The buccal shelf consists of cortical bone and is the primary stress-bearing area for the mandibular denture. Dislodgement of the denture with wide opening or soreness results from overextension of the denture in this area. As resorption takes place, the mental foramina will come closer to the crest of the residual ridge. In these circumstances, the mental nerves and blood vessels may be compressed by the denture base unless relief is provided. Pressure on the mental nerve can cause numbness of the lower lip. Like the mental foramina, the genial tubercles usually lie well away from the crest of the ridge. Obvious genial tubercles indicate a significant amount of resorption has occurred. The mylohyoid ridges are sharp and the area beneath them is undercut. The floor of the mouth is formed by the mylohyoid muscle, which arises from the whole length of the mylohyoid ridge. The ridge is sharp in the posterior area. The posterior part of the muscle affects the lingual impression border in swallowing and in moving the tongue. The retromylohyoid fossa is the area posterior to the mylohyoid muscle. The action of the mylohyoid in forming the lingual border of the denture must be recorded in the functional impression by asking the patient to lick the upper lip. These are other anatomical structures of the mandible which will affect the mandibular impression: the labial frenum, the labial vestibule, the buccal frenum, the buccal vestibule, the residual alveolar ridge, the buccal shelf, the retromolar pad, the pterygomandibular raphe, the retromylohyoid fossa, the tongue, the lingual sulcus, the lingual frenum, the premylohyoid eminence. The retromolar pad is a triangular soft pad at the distal end of the ridge. The muscle attachments in this area make it resistant to resorption. The denture base extends 2/3 up the retromolar pad, about to the area of the black line. This important landmark signifies the terminal end of the denture, as well as defining the occlusal plane of the posterior area. The denture should cover completely the buccal shelf. The terminus must converge rapidly to avoid displacement by the contracting masseter. This muscle is activated and recorded in the functional impression by exerting a downward force while asking the patient to close. Lingual tori are usually found bilaterally in the premolar area. The tissue is extremely thin and prevents a seal from developing. The default option should be to remove the tori, especially in the case of a complete mandibular denture. Most preliminary impressions are accomplished with alginate. When using this material, it is important to recall that the impression rapidly loses moisture and will distort. It should be poured as soon as possible. Unsupported alginate will distort from the weight of the stone, therefore a double pour method is required. Mount your complete denture simulations. The mandibular impression should always be taken first. Select a tray. The flanges ideally do not impinge on any frena. They should be 1/4 inch away from the frenum. The mandibular tray extends over the retromolar pad. Red rope wax may be added to conform the borders of the tray to the mouth and to confine the impression material, and to correct underextensions of the tray. The tray is rotated into the mouth and tried in prior to making the impression. Flanges of the tray may be adjusted to allow a better fit. Plastic trays may be warmed. Metal trays may be adjusted by bending. Practice placing the tray. Ask the patient to open halfway. Insert the tray by rotating the tray until it is over the center of the ridge. Seat the tray, lift and protrude the tongue, and then relax the tongue. Alternatively, ask the patient to lick their upper lip. Plastic trays should be coated with adhesive tack. Perforated or rim-lock trays do not require tack. You should strategically time your impression making so that undue delays in pouring may be avoided. Mix the alginate in accordance with the manufacturer's instructions. Seat the tray. Allow to set. Remove with one motion. Wrap in moist paper towel. The tray is tried in and adjusted similar to the mandibular tray. It is necessary that the tray cover the tuberosities, hamular notch, and vibrating line. The tray is rotated into the mouth, and the posterior extent is inspected. Ask the patient to close slightly. The labial vestibule is visualized. Use red wax to extend the tray, support the alginate, confine the material, and help adapt the tray to the borders. Using the finger, swipe alginate onto the palate and the labial vestibule. Ask the patient to close slightly. Rotate the impression and center over the ridges. Seat the tray. Pull the lip out and down. Ask the patient to suck down on the tray like drinking from a straw. Open and close the jaw. Move the jaw side to side. Once set, lift the soft tissue to break the seal. Close slightly and remove the impression in one motion. Inspect for adequacy of the impression. All pertinent anatomical structures should be noticed with no gross voids in the impression. For neatness, the tongue space is filled using a wet paper towel and alginate, using care not to obliterate the lingual border. Use a double pour. Remember never to invert wet plaster. Trim the cast, as in the illustrations below. The diagnostic cast should look approximately like the diagram. Be sure to preserve the vestibular roll and land area.